Good afternoon to those of you on the eastern side of the country, and good morning to those of you out west. Welcome to the Systems for Action Research in Progress webinar series. Systems for Action, as you know, is a national program of the Robert Wood Johnson Foundation. My name is Anna Hoover. I'm co-director of the National Coordinating Center with my colleague Glenn Mays, who leads our efforts here. And it is my privilege to be your host for the next hour as we hear about some of the exciting research being undertaken by one of the collaborating research centers of this now almost year-old program. Today's presentation is titled The Comprehensive Care, Community and Culture Program, and we'll be hearing from investigators at the University of Chicago. But before we do that, I'd just like to give you a little bit of a roadmap of where we're going today. I'm going to give you a little bit of background on the Systems for Action program for those of you who are not yet familiar with the work being undertaken by this effort. And then I will hand the controls over to our colleagues at the Collaborating Research Center at the University of Chicago, Dr. David Meltzer, who will also be joined in a bit by Dr. Harold Pollack. In commentary, we will hear from Susan Dreyfus from our National Advisory Committee, who is the president of the Alliance for Strong Families and Communities, and then we'll have time for questions and discussion. During the presentation today, as questions occur to you, we encourage you to go ahead and type those into the chat box on the bottom left of your screen. We'll be collecting those over the course of the next 45 minutes or so, and then we'll have some time at the end to explore these questions with our panel. Very briefly, because I want to leave plenty of time for our presenters to talk about the work that they're conducting up in Chicago, just a reminder to folks that the Systems for Action National Program is focused on rigorous research to identify the novel mechanisms for aligning delivery and financing systems in medical care, public health, and social and community services to improve health and well-being, achieve efficiencies in resources, and reduce inequities. You can learn a lot about specific focus areas for this work in our Systems for Action research agenda, which is available on the Systems for Action website, and we'll be seeing that link at various times throughout today's presentation. The Systems for Action work builds on a long history of health services research and public health services and systems research by expanding to incorporate additional sectors into this important work pointed toward improving health and well-being nationally at by focusing on the systems level. In addition to public health and medical care, some of the sectors implicated are here in front of you on this screen. You can see income support, education, workforce development, child and family services, community development, and finance. So there are a variety of different sectors that are included in this new work. We're also looking at studying the novel mechanisms for aligning systems and services across sectors. So how exactly, what are the mechanisms, what are the strategies that organizations are using to pursue alignment in ways that can improve health and well-being? Everything from innovative alliances and partnerships to incentives for individuals, organizations, and communities, community engagement, public values and preferences, cross-sector planning and priority setting. There are a variety of mechanisms that are being pursued, and we are looking to support the evidence base on what is working and how is it working. Operationally, our program structure has us here at the University of Kentucky and the National Coordinating Center working very closely with our collaborating research centers. Just last week, I believe, we heard from one of those collaborating research centers and on the work that they are doing, and that was Arizona State. Today we'll be hearing from our investigators at the University of Chicago, CRC, and we'll be hearing from the Indiana University, Purdue University, and Indianapolis group in coming weeks. We also have 4 individual research projects that have been funded to pursue the goals of the program. Today, our colleagues at the University of Chicago will be talking about their randomized trial of comprehensive care, community, and culture program. And you can see the other kinds of research that are going on across the different collaborating research centers and the National Coordinating Center. In terms of individual research projects, we have funded projects in the last few months at Michigan State, at the Los Angeles Department of Health, at the University of Delaware, and at Drexel, looking at a variety of different mechanisms for alignment. And with that said, and that brief background, again, I encourage you to visit our Systems for Action website to learn more about the research agenda and the work that is going on right now within the program. But with that brief background, I'd like to hand things over to our investigative team at the University of Chicago Collaborating Research Center. Dr. David Meltzer is the Pritzker Professor in the Department of Medicine, Harris School of Public Policy Studies and Department of Economics, and the Director of Health Lab and Center for Health and Social Sciences at the University of Chicago. A bit later, we'll be hearing from his colleague, Dr. Pollack, who is the Ross Professor in the School of Social Service Administration, an affiliate professor in the Biological Sciences Collegiate Division and Department of Public Health Sciences, and co-director of the University of Chicago Crime Lab at the University of Chicago. With that brief introduction, I will now hand the controls over to Dr. Meltzer.
Great. Thank you so much. It's wonderful to be able to join you today, and I'm going to do most of the presenting, and Harold will join us, I think, for question and answer. And we're really pleased to be part of the program and also to present this work on behalf of our colleagues within the University of Chicago and also some of the critical research centers that support this, including the urban labs, of which the health lab is a key part, but also addresses cross-sectoral issues, making it a nice place to house this sort of work, and the Center for Health and the Social Sciences and the Medical School and School of Social Service Administration. So we're pleased to be able to talk to you today. So we're going to talk about this work we've done on reforming care for patients at increased risk of hospitalization. And in order to explain the comprehensive Care, Community, and Culture Program, or C4P, which is really the focus of this proposal, I'm going to start by giving you a little background on our comprehensive care physician model, because the C4P program really builds closely on this initial work that we've done and is so heavily shaped by this that they really need to be linked together. Let me just say that all of the work we're doing is so obviously linked to healthcare reform, and obviously that's a changing landscape recently, but the fundamentals really must, in some sense, be the same. Obviously, one part of that is improving access to high-quality care, which involves reaching many, many people, and breadth of access is really critical. And as that breadth of access is gained, one also has to really address the needs of individuals through patient-centered approaches that understand the social and community context of healthcare. And we've seen, RWJ's Culture of Health initiative and some of Medicare's recent accountable healthcare communities, as key examples of that. But healthcare reform isn't only about improving access to high-quality care; it's also about controlling costs. And there, one of the really key facts is that when it comes to cost, some people matter more than others. We know that the vast majority of money is spent by a small fraction of the people. About 25% of Medicare beneficiaries are responsible for 85% of the money. And what that means is that if you're going to save money, you really got to focus on where spending is high, and that's a key part of what we're going to do here. Now, as you think about controlling costs, and particularly the ACA, there's a whole variety of different strategies: prevention, comparative effectiveness research, care integration, bundling capitation and ACOs. Many of those mechanisms, are sort of high-level ones in one sense, and beg the question of how you actually accomplish these things. And so institutions like the Center for Medicare and Medicaid Innovation really try to drill down and understand how we actually change care to do this. And the pilot work for the project we'll describe was funded by CMMI, and so that's a critical part of this. But also a critical strategy to reforming healthcare is also changing the workforce. And one part of that people have emphasized is reinvestment in the primary care workforce, which we know in the United States has eroded with incredible growth in specialization and effects of that on probably harming outcomes, but also raising costs. So the work that we're doing is heavily connected to that. Now, the context in which our work is sort of tied to specialization and primary care really grows out of work I've been doing for 20 years trying to understand the growth of the field of hospital medicine. And I think people know that traditionally in the United States we had primary care doctors who cared for patients both in clinic and the hospital for their general medicine problems. These doctors would round in the hospital in the morning seeing their own patients and then go to clinic in the afternoon. With this, there was incredible emphasis on continuity of care and the doctor-patient relationship. That was really dogma in the U.S., but not a model that was really used around the world. where inpatient and outpatient care were often separated. And then in the mid-1990s, hospitalists arose as doctors specializing in inpatient care, and an incredible explosion in the number of hospitalists around the country, caring for a larger and larger fraction of all admissions. And so I've been interested in a long time in whether that change in specialization was a desirable one and whether we could improve care by understanding why hospitalists arose. And as I've worked in this area, I've framed it as an example of sort of the advantages and disadvantages of specialization. Specialization has advantages, in terms of expertise. The more you do it, the better you do it. And these doctors focused on inpatient care and there all the time and learn more about doing it because they're there. But also disadvantages of specialization. And here in particular, there's the loss of the doctor-patient relationship and the high coordination costs and errors that happen when you have this sort of separation between inpatient and outpatient care. As I thought about this, sort of my initial theoretical take was that the optimal degree of specialization sort of balanced these benefits and costs. And this idea is deep in economic theory and medical ethics theory, and even in popular culture through things like the TV series Marcus Welby from the 60s and 70s, where in fact he was the generalist but struggled with that model. And so there's this tension. And there is, however, a newer sort of set of theories around specialization that argues in the context of this tension, you try to adjust the model. You try to improve handoffs or reduce the number of handoffs. And one of the emerging theories is something called an adaptive organization perspective. So when there are very high returns to specialization and very high coordination costs. So on the one hand, you want to be really specialized. On the other hand, it's really hard if you have very divided care. What you do is you focus your product on the needs for coordination. To reduce needs for coordination. So in other words, you don't try to do all things, but try to do one thing very well. This is what Clay Christensen at Harvard Business School has called the solution shop. And what the CCP model does is try to do a very good job of caring for patients at high risk of hospitalization. And so that's the foundation I'm going to build on. Let me explain a little bit more of that foundation. And it really goes back to this question of why hospitalists grew. Well, one theory says that they grew to meet the needs of hospital care, that they would have better incentives and ability to reduce hospital costs, and as patients got sicker and sicker in the hospital, you needed people who could be there all the time. But the reality is there's been very limited evidence of savings or improved outcomes with hospitalists. So even if hospitalists grew for this belief, it hasn't been held up in reality. There's another theory that we've come on, though, about the growth of hospitalists, and that is that they grew to meet the needs of ambulatory care. That over time we had declining hospital admissions and rising ambulatory volumes, and that this decreased the primary care physicians' incentives to see hospitalized patients because they just didn't have enough patients in the hospital to justify the trip in on a daily basis. And so as physicians organized into groups, it was easy to just turn over this care to hospitalists. To test this idea, we developed an ambulatory economics model that compared sort of the cost of a traditional primary care model where physicians saw patients in both settings compared to a hospitalist PCP model where they had different doctors in different settings. And our analysis suggested that this decision sort of balanced transport costs on the one hand in the old model where doctors had to drive back and forth versus communication costs in the new model where the inpatient and outpatient doctors had to communicate with each other. We actually tested this with data from the community tracking study and found incredibly strong support that these incentives were what motivated the growth of hospitalists. So the problem was that primary care doctors just didn't have enough patients in the hospital. So with this in mind, we can then say, well, boy, the old model just wasn't viable anymore, and accept that and move on. But before you sort of move on from that, you have to be aware of just the extraordinary literature on the value of the doctor-patient relationship, particularly for sick patients. We know that trust, interpersonal relationships, communication between the doctor and patient, and knowledge of the patient are all critical. And we know patients value seeing their own doctor in the hospital, even if they'll not necessarily pay a lot of money for that. But what's really amazing is some of the studies that show lower costs and better outcomes with continuity of care. Some of these are observational. Medicare patients cared for by their own doctor for more than 10 years have 15% lower costs. Lung cancer patients cared for by their own doctor in a terminal hospitalization have 25% lower odds of ICU use, presumably futile care. These are observational studies. But perhaps the most amazing to me is the one experimental study we were able to find, one by Jack Wasson in the 1980s in the VA. And what they did essentially is randomize about 800 complex patients, either to see the same doctor in every visit versus a completely different doctor in every visit. And in the continuous care group, they found almost 50% lower emergent hospitalizations, 40% lower hospital days, and 75% lower ICU days. So these are just, to me, compelling pieces of data that suggest that discontinuity is harmful and costly, especially for these frequently hospitalized patients. And it raises the question of whether better coordination of inpatient and outpatient care can improve outcomes. Well, we're not the first people to suggest that. In fact, Medicare for 20 years has been studying various demonstration projects to try to see whether improved care coordination can improve outcomes and lower costs. And the answer, unfortunately, is they've struggled. Several of the programs show reduces in admissions. Really, none of them consistently show reductions in total cost of care. One of the challenges of these programs is they often involve hiring care managers, and that creates another communication problem where the inpatient doctor has to communicate with the care manager has to communicate with the outpatient doctor, there has to be some communication by someone with the patient, and all those communications are costly and error-prone. So those things have struggled. There have been some important lessons from those programs: target interventions to high-risk enrollees, use data in a timely way, especially around hospital admissions, focus on care transitions in care, use team-based care, although cautiously, and keep the cost of the intervention low. So we concluded from this that we wanted to produce care coordination, but we have trouble paying for it. And you can see this in this figure where on the top you see current spending, which is sort of a little bit of ambulatory and a lot of hospital care. We want to shrink the size of that bar, but if we have to pay for care coordination there in the middle, and ambulatory care isn't going to shrink much because we're not doing much anyway and we need it to keep people out of the hospital, you have to decrease hospital care a lot, and that is just a hard thing to do. So the challenge is we want to find a way to produce care coordination, but we don't want to necessarily pay a lot of money for it. And this is where the idea of the comprehensive care physician program comes in. It's really the foundation for what we're going to talk about. The idea here is if the problem with having primary care doctors care for their own patients in the hospital is they don't have enough patients in the hospital, wouldn't it be great if we could have a subset of doctors who only cared for patients at high risk of hospitalization, so they could have enough patients in the hospital on a daily basis so that they could reliably spend their mornings in the hospital seeing those patients, and then in the afternoon be in clinic. And because they're only caring for patients at high risk of hospitalization, they can have a relatively small panel of patients, small enough that they can see them only in the afternoons. And give them all the ambulatory care they need while still having their mornings free to see them in the hospital. So the figure on the left sort of shows the idea we stratify patients according to expected hospital use. Those at low risk of hospitalization get an ambulatory-based primary care physician, and in the rare instance they're hospitalized, they get a hospitalist. But that doesn't happen very often, so that's not much of a loss. Whereas on the right, those with high expected hospital use get a comprehensive care physician. So what are some of the advantages of this? The most frequently hospitalized patients get their own doctor in both settings. Patients value continuity. Continuity avoids unnecessary repeat testing and treatment. The continuity also makes it easier for the doctor. It's easier to see a patient you know than a patient you don't know. All hospitalized patients get doctors with significant hospital experience and presence. They can even be specialists. Patients can choose their doctors, which they can't with a hospitalist model. This can be practical for a physician with a small panel size. You could use this for a patient-centered medical home or bundling or with readmission penalties. And if you're a small hospital, you can hire just a few of these doctors and with a small primary care base fill the hospital. What are some of the challenges? Will enough patients be willing to switch? Will doctors let patients switch? Will doctors do this job? Can it be economically viable? And so with all these questions in mind, we were very fortunate in 2012 to be funded by Medicare to build this program at the University of Chicago and do a randomized trial, which would eventually involve 2,000 patients. So just very quickly a few key elements of the program so you know what we're building on. We focus on high-cost patients expected who've been hospitalized at least once in the past year. We try to maximize the direct interaction of the primary care doctor with the patients. We keep the panel size small, about 200 patients per doctor, compared to 2,000 or 3,000 for most primary care doctors. They spend their morning on the wards, a little time off in the middle of the day, and then in the afternoon in clinic. We built a very tight interdisciplinary team with 5 of these doctors, and then advanced practice nurse, social workers, and so on, really organized around the patient's medical and psychological needs. It is a very lean interdisciplinary, multidisciplinary team. We keep costs low with these small, well-connected teams, focus on care transitions with simple IT, prepared ourselves to work across a variety of different payment mechanisms, try to support the team members. These are very sick patients, about 20% annual mortality rate, so a lot of need for supporting everyone. Rapid cycle innovation techniques were used with data-driven meetings and access to the right leaders. And finally, a rigorous evaluation, a randomized design, external evaluators, 2,000 persons, 1,000 in the intervention, 1,000 in the control. So very quickly, we started this in November of 2012. We built the program out. We recruited these 2,000 patients, finishing in June of this year. And I can't report the results publicly, but I can tell you both from a qualitative and quantitative viewpoint, it looks very promising. We have population health metrics that were driven by an evaluation plan focused on the triple aim of better care, better health, and lower costs. Seeing very promising data, but also promising trends over time. We use data on individual patients to help the CCPs improve their care. We focus every day and every week on the most complex and informative cases and use them to drive the model. And then really prepared ourselves to address some of the longer-term issues, like the financial models for expansion and sustainability, both under fee-for-service and under risk-based contracts. And we've made a lot of progress in doing that. And then we've started to work on dissemination. We'd really like to build a learning collaborative with others interested in this model already. You can see there several programs around the country are adopting models that are either very close to ours or at least involve the principles with them. And we've had interest from many other programs nationally and some internationally. So this is the foundation on which we're building. And we think the program is tremendously exciting. But we really, through this program, also see tremendous needs for improved engagement. We know that there are about 30% of the patients who are randomized to our CCP study who don't engage fully. They either don't make appointments at all, or they make appointments and then they don't keep them. And others make appointments but don't engage in the care plans as you would hope they would, and that only increases the challenge of low engagement. And we have the benefits we believe we're seeing despite this, but we know we can do better. All of these forms of engagement create opportunities to benefit patients, lower costs, provide efficient care. And one sort of stark statistic is that these patients who don't engage are more frequently admitted than others. They have average costs in the range of $75,000 to $100,000 per year, which is substantially more than about the $50,000 for those who kind of do engage. There's no one demographic profile of these people. They can be young, they can be old, they can be well or sick, they do tend to be more low income than others. They do tend to have less social support than some of our other patients. But the very best predictor of lack of engagement in the future is just simply lack of engagement in the past. So we tried to understand why these patients don't engage, and there doesn't seem to be any one reason or any one solution. And we've realized, moreover, that as we develop solutions for some of these problems, the reasons of lack of engagement for the remaining patients change. So this has taught us that in designing this program, we really need patient perspectives. And focus groups are one way to get those strategies, those insights. But the reality is the people who will come to focus groups aren't the people who we really want to engage because they're willing to engage. And so we've moved towards real-time opportunistic interviews with patients who are unengaged when they present to the ER or hospital to try to understand the needs. And those sorts of insights play a key part of our plan for the program. And let me sort of give you some of the examples of the things they talked about. Some of the things are cross-sectoral things like transportation and not understanding the system, child care. They're also just mood things. I don't feel up to it. I'm depressed. And as you dig deeper, you see a lot of that, but many different elements of these things. You know, it's interesting when you talk to patients about what would help. They tell you, well, you know, better transport, a more family-friendly environment, reminders. But when you dig in and you can see some quotes here and you look at what patients say about these things like transport, you say, well, it's transport, but maybe I'm just depressed. and maybe I just have to get my mindset different in order to really get myself doing these things. So it's complicated. So this sort of lays the foundation for the program, really, the Comprehensive Care Community and Culture Program. And essentially there are two main elements. One of it is, the first is really community health workers. And these are the ideas to take lay persons, often from the community, and bring them into the clinical team to really engage these patients who are not engaged in the community in their homes. Now, often community health workers are very disease-focused. They're not tightly linked to our clinical team. That's not what we want to do. We want our community health workers to cut across diseases, to address underlying social determinants, and to be closely linked to the team. Our goal, as I said, is to engage these patients in their community and home to try to address their unmet needs, to help them navigate the system, connect to resources, add reminders, assess the home environment, engage them psychologically to really pull them out of their home and connect them to the team. We're working with Sinai Health System, which is a local health system with tremendous expertise in the training of community health workers, and I can talk about that if people are interested. We're also building into this systematic assessment of unmet social needs to try to understand some of the cross-sectoral connections that these patients will need. The other part of our strategy is really what we're a community arts and culture program. We're calling the Artful Living Program. And this is really to try to engage the patient with others, with their peers, and with the clinical team through events like music, arts, theater, movie, books, and speakers. And part of this is just that they're pleasurable and provide opportunities for social support. But also we think that some of these can promote self-efficacy, exercise, cooking, even crafts program that allow patients to generate revenues for themselves to help address some of their life needs. We also think that some of these activities can really help patients explore and share values that enhance life and health. There are a lot of examples recently in the literature of the use of narrative, for example, Stanford's Letter Project, Photo Voice Project, and we think that our patients will be quite interested in these. But our beliefs about what patients will be interested in are nowhere near as important as what our patients say are relevant. So we know we need to really learn from the patients what they're interested in. I'll come back to that again in a minute. What are the goals of the program? To increase engagement and, again, to accomplish this triple aim of better care, better health, and lower costs. One key element that we've brought into this is a strategy called goal attainment. Goal attainment's, I think, a relatively new idea, and the idea is to ask the patient what their goals are, and then evaluate success by how well they are doing in reaching them. And this really contrasts with traditional evaluation, which picks domains that are believed to be important across patients. So our approach is to have each patient identify 3 health goals and 3 overall goals, and then rate their progress with this every 3 months to follow. And this is, I think, an experimental and developmental aim, but one that I think is tremendously exciting. So let me talk a little bit about the design process for this, because this is really critical. We have a faculty advisory group with expertise from humanities, arts, social work, behavioral economics, so academic disciplines, but also from the urban labs, which has 5 labs, 1 in health and 4 others in crime, education, poverty, and energy and environment. And we have access there both to practitioners as well as to policy experts. And as we identify needs in these areas, those are resources that we will draw on. We also have a patient and community advisory group. They help us develop ideas for programs, help identify problem-solving strategies that patients can use that often draw on their real-world experience. And there we also have a series of partners from the urban labs, Chicago Police Departments, Chicago Public Schools, and so on that give us some of these cross-sectoral connections. Now, as I mentioned earlier, one of the critical things is more than anything, we want to engage these most difficult to engage patients. And so in order to do that, we have to start by enrolling them. We enroll them, we discover who is going to be difficult to engage. And when we enroll them, we assess their interests, we probe unmet needs and interests. But only then, after we've assessed whether they actually engage, do they then become really the targets. And then we opportunistically probe these patients when they come in the emergency room or the hospital to try to understand their needs and interests. And our approach will really be to follow iterative experimentation. We have a lot of ideas from a whole variety of sources about things that will be interesting. We test these with patients. We see what seems interesting to them, and we're going to try to prioritize those interventions that engage the most difficult to engage patients and are really sustainable. Let me just drill down a little bit on some of the assessments that we're doing. We've been working with the folks from Health Leads, who many of you may know from their wonderful work engaging students in helping patients address unmet social needs. And they have a variety of screening tools. We're using actually one of their older screening tools, which we prefer in some ways to some of their newer ones, because it's broader. And so we ask for unmet needs in areas like food, housing, money to pay for basic needs, employment, education, applying for benefits. You can see legal, transport, personal safety, substance abuse, companionship, engaging in activities, healthy living, and so on. And so we ask about all of these, and patients tell us whether they have a lot, some, a little, or no needs in these areas. And you can see here for our first 36 patients we enrolled, the distribution of these things. The dark orange is patients who say they have a lot of needs, the lighter orange some, and the gray a little. And you can see there are some, money for basic needs on the right is pretty high, food is pretty high, insurance is pretty high, legal help, transportation is pretty high, companionship, enjoyable activities, healthy living on the far right. So there's actually a strikingly broad range of things. A few things are interesting, not so much child care, not so much housing, but broad things. And so now we've gotten this sort of first take on what some of these unmet needs are. One of the other things we do is we try to assess what activities they may be interested in. And you can see here some text of sort of how we ask it. We basically say we're developing new activities. We'd like to know what sort of things might interest you. And I just had one quote here from one of the patients. I'm interested in all of these, but there's the whole concept of me being alone. I don't think that's healthy. Maybe getting out. I'd be interested in going to a game or event or something. So you get the sense that, social isolation is really a key thing for people. And I think that's part of the opportunity that we have to engage people with some of these. When we ask people what sort of activities would interest them, we get a range. Family-friendly activities, opportunities to socialize, music and performance, narrative, arts and craft. Men seem interested in sports. Everyone seems interested in cooking and food. So these are some of the categories that we think seem promising. What are some of the barriers we hear about? Parking, transport, just being busy, lack of family interest to engage others, and just sort of the being tired and general dysphoric moods. And so we really hope that the social engagement can help pull people out of some of that last category in particular. We've just begun to have our sort of first events. Our first thing was a cooking class. It was taught by one of the members of our staff. And at the time we did it, we only had 10 patients in the program. We're now about 4 times, we're substantially larger than that. And 3 came. They had a great time. They learned things. They got connected to each other. They felt good about it. They wanted more time. We learned some things about how to lay out the room and others from this. But we're really just starting to sort of have these events. Throughout all of this, we've been very focused on sustainability. We try to use community resources as much as possible, both within the university and the broader community. We've learned that our patients themselves are tremendous assets and that their neighbors are as well. We really try to keep the cost of our programming low and promote self-efficacy by engaging the patients in themselves being the community that builds this. We're also trying to build the business case for payers and health systems. We're optimizing the use of existing resources like PACE and using navigation services. And we're running this as an RCT to try to be able to show cost savings and efficiencies for the system, like reductions in no-shows that are relevant across payment models. We've been exploring ideas like building a sort of internal patient economy where they can produce crafts, sell them, and use the revenues to help both themselves and support the program. We've been also thinking a lot about philanthropy. looking in particular at the role of multiple small donors and arts foundations and sort of micro-philanthropy, linkage of small donations to sales of some of the goods we may produce. We recently had a patient who died, and their family wanted to put a request for donations to the program in their obituary. And we've been looking at matching donations where we have somewhat larger donors. So let me give you a sense of the timeline. Our funding started in March. We were able to get the program launched by July and start recruiting about 15 patients per month, doing these needs assessment and interviews. We needed enough patients to have a first event, which we did in October. And by the beginning of this month, we have about 40 active patients. We've now been bringing in our community health workers and just starting to screen to hire them. They'll start probably in the next month, and with that added staffing, we'll be able to accelerate recruitment and meet their needs, getting us up to what we think will be about 45 patients recruited per month, which is a rate at which we've recruited for similar programs in the past. And then over the remaining part of the program, we'll complete our recruitment. We should be able to hit a target of 600 patients in the program in total. We'll be continuing to develop the program using the techniques that I told you that are very patient-centered and run our evaluation with both claims data and these quarterly surveys, and then continuing efforts to improve the program. We're just, as you can see, beginning this, and so we'll be working on disseminating some of the products, describing what we're doing and how we're doing it as we go along through presentations and papers and so on. And we'll be seeking funding to maintain the program. We've done very well so far in keeping the clinical parts of the program supportable through clinical revenue streams, and we'll work to make sure that the other parts of this are as sustainable as possible. The trial that we're doing now, we think is probably going to be not large enough to give definitive evidence about efficacy. So we're starting to seek funding for what we think would be a really definitive RCT with a larger sample size and a longer follow-up. So I think that is the end, and so thank you all for listening. I know I went quickly, but I think we have time for questions.
Well, thank you so much, David. And before we get to questions, I'd like to remind folks that you do have a chat box in the bottom left-hand corner of your screen. Please enter any questions that have been occurring to you into that box. But first we want to hear from a member of our National Advisory Committee who's going to provide a little bit of commentary on what we've heard today in the Systems for Action program and this particular project. Susan Dreyfus is the president of the Alliance for Strong Families and Communities. And with that, I will hand the controls over to Susan.
Great. Thank you so much. And thank you, Dr. Meltzer and Dr. Pollack, for this really exciting project. I'm sitting here really quite impressed with what all you are doing. It's wonderful to be a member of the Systems for Action project funded by Robert Wood Johnson under the leadership of University of Kentucky, as we work across systems, across fields, together to try to build the evidence for aligning multi-sector delivery and financing systems to improve population health. What I find very exciting about this project is I think that it is one more indication of why I think we can all be very hopeful about the future direction of healthcare in our country. Because what's really happening is, I think at a cross-sectorial and field level, we are creating the evidence to build what will become our version, our new version as a nation of standard of care. As we think about it today, and as we will be thinking about that more integrated approach to an evidence-based standard of care in the future at this intersection of health and social care. I am reminded, as I listen to Dr. Meltzer, and that's because most of my career has been in the public sector running human service delivery systems, from children and families to older adults and everything in between, is that it reminds me very much of our early days in human services as we were perfecting what we called wraparound. Many of you know that, as it started out with children's behavioral health and now has been adapted to many other populations, including persons who live with developmental disabilities. Approaches that we took have had making sure that money follows people, and that we were looking at it through the perspective that what everybody needs is not always our formal services, but oftentimes it's their authentic engagement with us in directing what it is that they need, but also our recognition, which is what I love about this project, that oftentimes what really helps people to move forward in their lives is through natural supports that we create around them and that we recognize exist in their lives. To me, this project just hits the bullseye on all of those fronts. I would say that one of the things that it's also giving us the opportunity to do is that we all know what we're trying to do here is to truly change at a systemic level. And to do what we're trying to do to build population health, we've got to take the broadest view of that systems level, even beyond the healthcare spend. And so I think this project also lays open the opportunity for all of us as we keep building this evidence through the System for Action projects across the country, is I think this whole notion of the blending and grading of funding, the opportunity to baseline expenditures so that a reinvestment can be made toward the front end and into what works. I think if I were to say the one thing that I also think this project gives us the opportunity to do is to really make sure that yes, we are affecting changes in how people experience the healthcare delivery system, but whether or not we're also really studying underneath this how what knowledge we are going to gain, which I could hear as Dr. Meltzer was presenting this. I could just think about all the opportunities we had to build knowledge about unmet needs within communities, even at a neighborhood level, as it relates to these socioeconomic factors that in the Health Leads assessment instrument that they are using to really get at capacities. I think sometimes we overestimate that all of these capacities are readily available within our neighborhoods across the country, and my own human services background tells me that's not always the case. And I think this project also provides a unique opportunity for us to not just see what it takes to improve health of the populations being served, but is there knowledge that we're going to gain about unmet needs within communities that allows us to start thinking about the reinvestment of savings in building capacities within neighborhoods that are critical to building culture of health. So I just see so many reasons for great promise and applicability of this project and the knowledge that comes out of it as we continue to build an evidence-based new version of what standard of care in America means. But I also think there's something else happening that's very exciting on this call in and of itself, is I think we are creating a new version of what is really a cross-sectorial and field approach to our version of grand rounds that not only gets us to perfect, again, that standard of care, but to systemically look beyond health care for where there are growing needs, issues, gaps, disconnects, so that our work can be informative not just into Medicaid, Medicare, and healthcare spending, but can be informative into those areas that, again, are a great alignment around the social determinants and the economic determinants of health. So Dr. Meltzer and Pollack, thank you very much for this work, and it'd be great to hear what our callers think about the work and what questions they might have. Thank you.
Thank you so much, Susan, both for your comments today and for your service as a member of the National Advisory Committee. We really appreciate all your efforts in support of this program. We have been gathering questions. Again, if you have questions, please add them into the chat box in the bottom left-hand corner of your screen, whether for Drs. Meltzer and Pollack or for Susan Dreyfus. We'd be happy to hit those questions as we move along. And the first is for our University of Chicago investigators, from Barbara Postman, who asks, what are you thinking would be sources of sustainable funding for those services not directly billable as a medical service?
Yeah, maybe I'll start and Harold will add. I think there are multiple answers to that. One thing I just start with is there are a lot of services out there for free. And part of this is just navigation. One of the things I've been really impressed by is in talking to our patients, we discover that one person's unmet need is another person's need that got met by something that was available, but the person who didn't get it just didn't know. And so some of the funding's already out there. And one of the great challenges of social programs is that the most empowered people often get them when the least empowered people don't. And so if we can help those people reach those things, some of the funding is already there. And we certainly see, even in things like arts programming, there's so much unused capacity that one can find those things. Now, that much said, there are clearly going to be areas we identify where there are needs that are not being adequately met in the community. And the hope is that we can help to generate the evidence base that shows that if you can find ways to address those needs, you can reduce healthcare costs, improve outcomes, and that's going to motivate spending on those things or reallocation of funds towards them. But I honestly think that in the short term, the very most important thing is to get people access to the resources that are out there that they could be getting but aren't. And I think in the short run, that's probably, if you're going to count dollars, where the dollars come from. But obviously that's not the only answer in the long run. I don't know, Harold, if you want to chime in also.
Yeah, well, I'll add one thing. I agree with everything that you said. I think one of the interesting challenges is also how the resources that are out there need to be tuned a bit so that they really help the kinds of people that we're trying to help in this program. So I'm very interested in financial coaches and how they can help people manage their personal finances. And many of the patients that we're dealing with have all sorts of issues from budgeting to insurance that they need financial coaching. We probably have to work with the financial coaches so that they know more about the specific circumstances of this population. And so I think one of the entrepreneurial opportunities is to say, let's find what's out there. There already are actually a lot of resources out there for people to get help with their personal finances, but then how can we really make those more effective for this population to leverage those well? And I think that that's one of the things that I hope we can accomplish in this project. So, if we take people who are already doing these great things for people in the community, but to say, okay, how can we support you so that you can help our folks, most effectively? So so I think I'll leave it there, but I think that's one of the interesting challenges.
The Robert Wood Johnson Foundation's Culture of Health initiative, of which the Systems for Action program is a piece, focuses on two endpoints, not just health but also well-being. And to my mind, the artful living piece of this work really begins getting at that well-being component. Now in the presentation, Dr. Meltzer, you talked some about some of the partners that you all are reaching out to help identify and fill some of those gaps in terms of cultural, artistic, narrative gaps that you've been identifying, opportunities to help people strive not only for improved health but also well-being. So I'm curious if you could talk a little bit about your process of building those partnerships, your process of engaging those stakeholders who are working with you to help fill some of those needs.
So it's really interesting. It turns out, at least in our environment, to be incredibly easy. There are so many first of all, we're in a university community, so there are 1 million student groups. There are 1 million cultural institutions that are around us. But even if you took away the university community, there are so many wonderful musicians and theater groups scattered in this community, not necessarily an affluent community, but an incredibly rich community that we could, if we just wanted to run programs, we could run programs every single day of the week, all year long. The issue really is, it all takes staffing to organize and bring people. And we want to bring the people for whom it's really going to matter. And so we're really taking seriously that we have to start by understanding what our patients want who we're not successfully engaging. So it was interesting in thinking about this presentation. I spent a lot of time on the front end, and I felt a little bad about it. But the reality is the front end defines who we're already able to engage, and it's that group that's left over that we have to sort of find and then target. So we've had no problem finding cultural events. Our patients alone, they're artists, they're dancers, they're storytellers, they're chefs, poets. Like, these are our, frequently hospitalized Medicare patients. There is so much, knowledge and wisdom and, just greatness in these patients. And the real trick is to figure out what we really focus on, because we know we can't successfully run many, many events. We know we want these things to be successful when we do them, because we want to create a great experience for our patients that brings them back. So we're really putting a lot of work in up front to first recruit patients and then start to understand their needs. And I mean, talking about the arts, the same thing's true with respect to unmet social needs. We have these bar graphs that show, how many patients have this need or that need. But now we have to go back to them and say, okay, you said there was a challenge with X. What exactly is the challenge? And that's a one-on-one discussion. And when we put together a group of those one-on-one discussions, then we can start to figure out how we then develop programming that helps them address that. So, there's a lot of talk about patient-centeredness, but like doing this project, you really live and feel it, because you realize you got to talk to people if you're going to understand what they need.
Thank you so much. Well, I'd like to thank Dr. Meltzer, Dr. Pollack, and Susan Dreyfus for being with us today as our panel. Would like to encourage those of you on the call who are interested in this work to continue following along. In the presentation, David talked about some of the dissemination work that's beginning, and obviously this particular call is one piece of that. This cross-sectoral grand rounds, as Susan called it, and a phrase that I promise I'm going to be stealing. I like that very much. So we're going to continue following this project through this call and others, but we also have a web page here where you can go to find any new products that are available from this research. We hope that you will bookmark it, pay visits to it, keep up with what's going on with the program, and continue coming along with these Research in Progress webinars. As I said, we recently heard from our team at one of the other two collaborating research centers at Arizona State University was our last call, and coming up next, December the 7th, we'll be hearing from the investigators at our Indiana University Collaborating Research Center, and we hope that you'll join us for that. All of these Research in Progress webinars are archived on the Systems for Action website. We hope that you'll pay a visit there and see if there are other sessions that might be of interest to you. Coming up later on in December, after we hear from our third and final Collaborating Research Center, we'll be hearing more about our intramural research here at the National Coordinating Center. We do hope that you will join us for those webinars and that you will check those archives as you move along. Systems for Action is, as I mentioned at the top of the hour, a program of the Robert Wood Johnson Foundation. I want to thank our team here at the National Coordinating Center for all of the hard work they do to put this webinar series together, especially Ann Kelly, our program manager who is charged with this work. I also want to thank once again, before we give you back 5 minutes of your day, Drs. Meltzer, Pollack, and Susan Dreyfus from our National Advisory Committee for their excellent presentations. It has been a pleasure to learn more about this program, and we look forward to talking with you all many, many more times as this work progresses. Thank you, and have a terrific day.
Thanks so much.
Thank you.